Meaningful use is a terrific vehicle for conveying that purpose, because if health information exchange is a part of meaningful use and the incentives contained in the meaningful use framework are lined up behind it, we can create for the first time in the history of our health system a business case, an economic rationale for exchange. And that rationale emerged in fairly basic form in the Notice of Proposed Rulemaking we issued in December, and it remains a critical goal of the administration, and it was a critical goal of the Congress. We, in fact, were instructed to make sure that exchange occurred as a part of meaningful use. But wishing it to happen and even incenting it to happen is not sufficient. We have to put in place some technical supports. So one of them is standards. And even more than standards, something called implementation specifications. Now, these were terms that I had very little familiarity with when I got to this job. As a sidelight, I should tell you I'm not an informatician. I'm not a programmer. I never sought to be. My wife thinks it's a huge failure in vetting that I got to have this job. But I have learned that if you want systems to talk to each other, just like if you want people to talk to each other, they have to have a common language. And the way that common language finds itself into computing technology is through setting definitions for common terms and specifying ways of representing them in electronic form. You need common vocabularies, and you need common ways of defining those things electronically. And you can't just set standards. You have to actually go the next step and write out a whole set of very specific directions about how information will be represented and how it will be exchanged. So the job for doing that is a regulation that we put out in interim final form in December and that we will reissue in final form before too long. And we hope it will be an important step on the evolution toward a system that really permits exchange. And of course, comparative effectiveness research depends ultimately and to some degree primarily on effective exchange of information. Now, setting those standards is part of the solution, but then you also need a pathway. If you get people speaking English, that's great. But you then have to provide a method of them projecting their messages geographically over space. Now, we've got this thing called the internet, and it's available to use, but we know it's not secure. So we need to find ways of exchanging information that are secure and that are private. And we also need to find ways of creating the basic infrastructure for exchange, to wit. Who is Dr. Greenfield? Is he licensed? Where does he live? If I send an email to Dr. Greenfield, do I know that he's a licensed physician who is authorized to have that information? Or does he work for the Russian mafia? Well, someone has to identify him, certify his email address as being associated with him, and attest to that and be held accountable for that. And that has to be done for the roughly 740,000 practicing physicians in the United States, and all the clinics, and all the physical therapy offices, and all the hospitals, and all the surgery centers. Just getting a directory of email addresses that's legitimate and authoritative, and also making sure that those where it's desired are kept private. That's a huge challenge. And then there's this issue of data held by different groups. How do we make sure that Medicaid and public health data flow into this exchange system? Got a lot of really old, creaky systems out there. We have to create bridges between those systems and the internet. And data has to flow like as blood does in blood vessels to the right place at the right time. So we are working, a lot of the work we do that isn't visible takes the form of developing standards and protocols and policies to channel information privately, securely, accurately, authoritatively on the internet. And we're developing several mechanisms for doing that. And here again, humanware is critically important because people have to trust that that information flows, and when it's flowing, that it's safe. So encryption of that information in transit is a really important part of the process. And for reasons I discussed earlier, making sure that the people who can dip into that information as it travels are authorized and by the patient to dip in to that flow of information. We've actually asked the states to play a major role in this activity. Now, why the states? We could have tried to do it all from the federal government. Could have said the federal government is going to orchestrate from the Bering Straits to Key West, from Maine to the tip of Baja California. We're going to orchestrate a massive exchange network. I don't want a show of hands, but if I asked for a show of hands about how many were confident that the federal government could do that, I suspect there would be, we wouldn't have a unanimous opinion about that. The other thing we could do is kind of say, let's let each community do that. Take charge of this construction project. It's not actually a construction project, it's much more like the creation of consensus around policies and procedures and protocols and standards. Well, there are thousands and thousands of communities in the United States, thousands of counties, and within those counties there are towns and cities, and each one of them has their own culture, their own needs. The old truism that healthcare is local is also true of the use of healthcare information. So since we live in a federated political system, we figured the states were created for a reason, and one of the reasons they were created is that they are closer to the ground than the federal government, but not so close that their perspective is totally local. What's more, they license physicians, they license nurses. They know who the licensed physicians and nurses are in their jurisdictions. So if you want authoritative directories, the states have a head start. Just have to call their Board of Registration in Medicine, Board of Registration in Nursing, Board of Registration in Pharmacy, the public health group that licensed the hospitals and the clinics, to get authoritative lists of people who are entitled to receive private health information. They also sit on top of Medicaid data. They also receive immunization information, who's immunized, who's not. They regulate many aspects of the healthcare system within their jurisdictions. So the states were a logical group to involve, and we've put over $500,000 into the 56 states and territories to get them mobilized as our partners to create health information exchange. We've also recognized that to do what you want to do for comparative effectiveness research, we may need some new methods of data aggregation, some new technical approaches to taking information from many, many disseminated locations, clouds located wherever, individual doctors, CPUs, integrated delivery networks, healthcare systems, information systems. Extracting that information is a technical challenge that we have not approached and that undoubtedly has some technical innovation required. So we funded, along with 3 or 4 other groups, we funded one major group at the Mayo Clinic on a competitive basis to do advanced health information technology research, computer science research on health information exchange and how it should be accomplished. And then we created a whole series of demonstration programs around the country called Beacon Communities. The purpose of these Beacon Communities is to show what health information technology is capable of doing. In a sense, to try to solve some of these problems on the ground. To give groups and locations that had an edge already, that were advanced in their local uses of health information technology, to give them an extra step forward, an extra push toward the future. And they are tasked, under the cooperative agreements that fund them, with showing demonstrable improvements in health and efficiency of local health systems over about a 36-month period. And they probably could never do that without health information technology. But we picked them because they have relatively advanced systems. And we expect that a bunch of them are going to work very avidly on health information exchange as one method to get to where they need to get. One of them actually is Indianapolis, whose health information exchange is already a beacon of effective use of health information. So we're doing all these things that are in service of your ambitions and of our needs to have better information about healthcare and its uses and how those uses compare to one another.